Hello. Today we will be having a discussion about the placement of both the limb and the chest leads on the body before we get the ECG. There are four limb leads which we place on the body. This is remembered with the mnemonic read your good book. When we call read, that means R red, your Y yellow, and green G, and book black, because these are the three colors of the limb leads: red, green, yellow, green, and black. These are placed clockwise on the four arms of the body, upper and lower. Red is placed, you can place it all from here to here, but it is placed for the because there is a less muscle mass, so it is placed on the right forearm. Red is placed on the right forearm, and yellow is placed on the left forearm, and green is placed on the left lower limb or left leg, and black is placed in the on the right lower leg. So this is how the four limb leads they are placed on the limbs. Read your good book. Red, yellow, green, and black. Of these four ECG limb leads, black is used for the earth purpose. So it is futile from our point of view that it doesn't actually has got any. It hasn't got any representation of the ECG paper. So in reality, we have three limb leads: red, yellow, and green on the three limbs. The fourth is used for the earth purpose. So that sort of makes a triangle. When ECG was devised, obviously so many years and decades back, probably a century back, then there were only three primitive leads: lead 1, 2, and 3. These were the three limb leads which were actually gathering information from the heart on from three different directions. Lead 1 is located between the left shoulder and the right shoulder. Lead 1 has got a positive pole on the left shoulder and a negative pole on the right shoulder. Lead 2, it was located between the left lower leg, or foot, you can call it a foot, left foot, and right shoulder. It has got a positive pole on the left foot and a negative pole on the right shoulder. Lead 3 was located between left foot and the left shoulder. It has got a positive pole on the left foot and a negative pole on the left shoulder. So these were in effect the three primary limb leads: lead 1, lead 2, and lead 3. But there were some areas of the heart which went uncovered. So, as the machine became intelligent and people started devising the ways actually to get some information from the lead 1 and some information from the lead lead 1 and 3, they actually made a lead AVL. They got some information from the lead 1 and lead 2, they made lead AVR, and they got some information from the lead 2 and lead 3, they made a lead AVF. The AVF, AVR, and AVL, the word A stands for augmented, and V for voltage, and R represents right, L represents left, and F represents foot. So, by gathering information from the basic three limb leads, they generated another three limb leads which are not existing actually on the body, but it is something which the machine generates. Between lead 1 and 3, they have lead AVL. Between lead 3 and 2, they have lead AVF. Between lead 1 and 2, they have lead AVR. Out of the, now it becomes a six limb leads. Three of them are bipolar and three of them are unipolar. 1, 2, and 3, these are the bipolar. They have got a positive pole and a negative pole. And the AVR, AVL, AVF, they are directly looking at the heart. They are unipolar limb leads. So out of these six limb leads, AVR is not looking at any wall at all. It doesn't represent any wall. Lead 1 and AVL, it is looking at the lateral side of the heart, lateral wall of the heart. Lead 2, 3, and AVF, they are located inferiorly, so they are looking towards the inferior wall of the heart. So inferior wall is looked upon by the 2, 3 and AVF, and lead 1 and AVL, they are looking at the lateral wall. Now this is the lead placement of the limb leads. So if someone actually puts the limb leads wrongly, how we know on the ECG paper? Because the wave of depolarization is going towards all of the limb leads except AVR. AVR is sitting here and the wave of depolarization is going leftward and downward. So it is always a negative lead. P is negative, QRS is negative, and T is negative. While all other leads, normally they are positive. They have got a tall R wave and a very small S wave. Lead 1 would be positive, AVL would be positive, 2 will be positive, 3 will be positive, and AVF will be positive. But say someone has wrongly placed the electrodes on the body of the limb leads. For example, red is placed on the left side and yellow is placed on the right side. Then AVR would become a positive lead and 1 and AVL would become a negative lead. So this is how the malposition of the limb leads can be detected. There is another case where AVR is positive, and that is in cases of the dextrocardia when the heart is located on the right side. Because heart is normally located on the left side, so AVR, when it sees the wave of depolarization going away from it, it generates a deep S wave and no R wave or a very small R wave. Most of the time it's completely negative lead. While the rest of the limb leads, 2, 3, AVF, AV1 and AVL, they are all positive limb leads. Now these were the limb leads. Now we talk about the chest leads. There are, because it's a 12 lead ECG, there are 6 chest leads, and we place them in a way that first of all we anatomically locate suprasternal notch. From the suprasternal notch we come downward, and there is an angle of Louis or a ridge which we call the manubrium sterni. Just parallel to the manubrium sterni on the right side is the second intercostal space. Then we come down, this is the third intercostal space, then is the fourth intercostal space. So on the right side of the sternum, in the fourth intercostal space, in the area very near to the sternal border, right sternal border, we place chest lead 1, and chest lead 2 is placed exactly in the fourth intercostal space on the left side, exactly opposite to the chest lead 1. So chest lead 2 is placed in the fourth intercostal space in the left peristernal area. Then we do not place chest lead 3 first, but we lead chest lead 4. We mark the clavicle. This is clavicle. In the middle of the clavicular is we draw a line downward. This is the mid clavicular line. When the mid clavicular line, where it crosses the fifth intercostal space, we place the chest lead 4. So chest lead 4 is placed in the fifth intercostal space in the mid clavicular line, and chest lead 3 is placed between lead V2 and V4. So then comes the chest lead 5. Chest lead 5 is placed in the fifth intercostal space on the left side, and it is placed in the anterior axillary line. This is axilla, this is anterior axillary line, and when it crosses the fifth intercostal space, this is the place where we put the chest lead 5. Chest lead 6 is placed in the fifth intercostal space on the left side in the mid axillary line. So chest lead 6 is placed in the fifth intercostal space in the mid axillary line. Chest lead 5 is placed in the fifth intercostal space in the anterior axillary line. Chest lead 4 is placed in the fifth intercostal space in the mid clavicular line, and chest lead 2 is placed in the fourth intercostal space on the left side of the sternum, and between chest lead 2 and 4 we place the chest lead 3, and chest lead 1 is placed in the fourth intercostal space on the right side of the sternum. And how we locate the chest lead intercostal space 4? We locate by first localizing the suprasternal notch. Going a little bit down, we find the angle of Louis, which is a ridge in the sternum, and then we come towards the right side. It is the second intercostal space. Downward comes the third intercostal space, then is the fourth intercostal space. Now, one very important thing to remember, because the chest lead 1, V1 and V2, they are located on the right side of the sternum, very near to the septum. So when first of all in the conduction pathway, first of all there is depolarization of the septum. That septal wave depolarization goes towards lead V1 and V2 and generates a very small positive deflection, which we called a small R wave in these two leads. But at the same time, that septal depolarization is going away from V5 and V6, and they generate a very small negative deflection. That is what we call physiological Q wave. Lead V3 and V4 are somewhere in the middle of this transition, so they have got an R wave and an S wave almost equal size. But as we move towards the lateral side of the chest wall, then and we go toward the location of the V5, chest lead 5 and chest lead 6, the wave of depolarization is going directly towards these two leads. They are located right in front of the left ventricle muscle mass. So it generates a larger positive deflection in the form of R wave and a very small downward deflection in the form of S wave. Because wave of depolarization of the left ventricle, which is a larger muscle as compared to the right ventricle, is going away from lead V1 and V2. They generated a deeper S wave, and the smaller R wave was because of the initial septal depolarization, as I already mentioned. So there are 6 chest leads and there are 6 limb leads. All of the limb leads are positive normally except the AVR. And in terms of the chest leads, they keep on becoming positive and positive as we move from V1 to V2, V3, V4, V5, V6. Because when it comes to the chest leads, the major muscle mass is the left ventricle. So those leads which are located towards the left side of the chest, towards the front side of the left ventricle, they generate a positive deflection because they see the wave of depolarization coming towards them. So they make a tall R wave and a small S wave. Small S wave because of at the end of the at the end of the this conduction process, the wave of depolarization goes towards the fibrous tissue that separates the atria from the ventricle. So that away movement of the wave of depolarization from the V5 and V6 generates a very small downward deflection, which we call S wave. So whenever someone wrongly places the chest leads, there would be a reversal of it. There would be tall R wave in lead V1, V2, V3, and there would be very small R wave in lead V4, V5, V6. Or there would be a very deep S wave in lead V5, V6, and V4, and there would be a very small S wave in the lead V1, V2, and V3. So we need to check the positioning of the chest leads in that case. So by looking at the chest lead and the limb leads, we can have some idea about the functionality of the heart, and that is one of the very important factor in determining the cardiac contractility, depolarization. Because at the end of the day, we need to understand one very important factor, that ECG is all about the electrical cardiac activity. This hasn't got anything to do with the mechanical functioning of the heart per se. Like for example, heart contractility can be elicited from the body by like looking at by palpating the pulse or feeling the pulse. But electrical depolarization and repolarization is what's related with the ECG. So all the positive deflections are wave of depolarization. All the negative deflections are wave of repolarization. So the whole concept of depolarization and repolarization is connected with the ECG. The process of mechanical functioning of the heart is what we actually auscultate, what we feel the pulse. So these things are mechanical, but obviously electrical activity is always followed by the mechanical events.